welcome to the Complete Health Podcast, the podcast that brings you a complete view of everything healthcare, exercise as medicine, and a lot more.
We're your hosts, Helen O'Leary and Reece Noble, physiotherapists at Complete Physio and Pilates in London.
This is episode 5, the second part of our chat with physiotherapist Annabel Hawker, where she talks about multi-directional instability of the shoulder.
I really enjoyed this chat. MDI of the shoulder is an area many physios don't know a lot about, so this was a very educational one for me, and I hope it is for everyone listening.
Keep an eye out over the next week for the third part of our chat with Annabel, where we discuss common horse riding injuries.
Hello and welcome to the Complete Health Podcast. I'm your host, Reece Noble. I am here with my co-host, Helen O'Leary.
Good afternoon.
Afternoon, it is indeed. And we are here for part 2 with our chat with physiotherapist and Pilates wonder instructor, Annabel Hawker.
Hi guys, nice to be back.
So for those of you who haven't listened to the first episode with Annabel, we went through Pilates. I sat here mostly in silence as these two guys chatted about Pilates for half an hour.
We got a bit carried away.
Yeah, and it was obviously their passion because they rolled through and I had to stop because we could have been here all day, I think. But some really good insights there, both for therapists and for potential patients. If you're wondering what clinical Pilates is and what it can be used for, I definitely recommend going back and having a listen to that. So part 2 of our chat, which we're going on with now, is about one of Annabel's specialties, which is multi-directional instability of the shoulder. So shoulders are a wonderful joint, but they're also wonderfully frustrating. Sometimes they move in lots of different areas. They basically can put our hand wherever we want to, but with complex movement comes sometimes some complex injuries. Yep. So a good one to have a chat to Annabel about. So Annabel, what is it? What's multi-directional instability of the shoulder?
So multi-directional instability, if we're going to go with the dictionary definition of it, is instability of 2 or more directions in the shoulder, and it has to include an inferior, so a downwards instability in the shoulder, and then generally it's going to be either an anterior forward or a posterior backward instability, or sometimes all 3. And it can come about from a couple of different reasons. So it can be what we call almost a congenital issue. So if someone has a connective tissue disorder such as Ehlers-Danlos or hypermobility, then obviously their shoulder is going to be looser than the average person's. So they're going to be more likely, they'll definitely have a multi-directional laxity, which means a looseness in the shoulder. Yeah. It only becomes instability when it's symptomatic. So when it starts to give them pain or problems, or the shoulder starts to pop out, or they feel it shifting around and they're uncomfortable with it. So that's what multi-directional instability is. We can have then a traumatic instability. So say if our footy player got hit on the field and his shoulder popped out, that's generally going to be most commonly out the front, and they're then generally going to continue with an out the front instability. So they're not generally going to then develop downwards or backwards unless there's been a significant disruption to the structures in the shoulder. So that would be a more structural instability rather than necessarily mechanical instability.
Okay.
So would you say then that multi-directional instability was more mechanical or structural?
So it can be both, but what you can see, so I've had patients who've had a clean MRI, so their MRI looks pristine, yep, and they sneeze and their shoulder pops out. So clearly there's something going on there.
Yeah.
So there's kind of 2 categories of multi-directional instability. So there'd be one which we'd say is a structural multi-directional instability, and that's commonly after an injury. So a skiing accident, a footy injury, a fall, where there's been damage to the structure of the shoulder joint. Now our shoulder joint looks like a golf ball on a tee, so it doesn't actually fit together that well. Yep. It means we have beautiful mobility at our shoulder, but we sacrifice some of that stability. So if we think about our other ball and socket joint, which is our hip, the hip socket hugs the ball, so it's really nice and stable. It's much less common to see a hip dislocation. Hopefully none of us ever have to see one in real life.
They're not fun when you see them.
I mean, I've seen 2, both in rugby, both very traumatic.
Yeah, and requires a lot of force for it to happen.
Exactly.
So that's, the shoulder requires a lot less force than the hip to be dislocated. And so if it was a structural instability, it would generally be after what we'd call a more traumatic first episode of instability with a fall, and potentially some of the tissues around the shoulder have been damaged, the most commonly being the labrum, which is like a little calamari ring that's
That's how I describe it. That's how I describe it as well.
So, and it kind of acts like a suction cap. So even though they don't match up very well, if that labrum's intact, it kind of acts like a suction cap. You know, like when you put something on the wall of your shower, and as soon as there's a little crack in that no longer sticks onto your shower screen anymore. So that's basically what happens. And if there is something in there structural and you've rehabbed it fully and they're still getting instability, then definitely they would need a surgical repair or consider a surgical repair. So that's kind of number one. And they will generally have more instability into one direction. So the direction of their structural lesion. They may have sensations of instability in other directions, but generally their predominant direction will be related to their structural lesion. Then we've got our mechanical instability, and they're the guys that, and I say guys, but it's normally women, to be honest, more commonly women, and more commonly younger women, who have either some sort of congenital laxity in the capsule, but often it's actually a muscular issue. So as we were saying before, it's not a very congruent joint, it doesn't sit together very well, so we're very reliant on our muscular structures to actually provide the stability. And I sort of liken it to an orchestra. So if one of the muscles is out of tune, as it were, suddenly that lovely concerto of lifting your arm starts to not work so well. And unfortunately, what then often happens is to try and compensate, other muscles switch on. And so then we get into this cycle where the incorrect muscles are switching on to try and help, which will often then create more pain, apprehension, instability. And there's actually a whole lot of research starting in more of this sort of side of things, looking at whether there is a vagus nerve involvement or kind of a danger response to it. And so actually they're now starting to recommend, you know, if you are someone who's a multi-directional instability and you do dislocate your shoulder and you can't get it back in, to actually try and lie down at home and actually just relax and allow it to pop back in on its own, rather than going to A&E and have it further tractioned, which is then going to further pull on all those structures, which is then going to create further, you know, danger responses in that shoulder and potentially increase the muscle spasm, which is what caused it to pop out in the first place.
Sorry, Helen, you said that nervous system response.
Yeah.
Is there not to stereotype, but is there a personality type that you commonly see them in, like of anxious people, or?
Well, I mean, I'd be pretty anxious if my shoulder was popping out all the time.
Actually, it's a chicken and egg.
It's a chicken and egg. It's quite hard. Like, I mean, obviously, you know, it's not a nice feeling to, like, I have a shoulder that does slide, you know, it's never popped out, but it does slide around, and when you get it in the wrong position, it does not feel good, and it gives you a bit of a fright. So I think
sympathetic nervous system.
Yeah, definitely. And so if you have a shoulder that's sliding around in there all the time and all those receptors are getting pulled on the whole time, then there's definitely going to be that level of upregulation of the sympathetic nervous system, which is our fight or flight response. So if you're getting ready to flee a lion, you're not in your calmest state of mind at that time. So I think there definitely is a level of anxiety. Whether that's causative or effect or a combination of both is very difficult to say, but definitely addressing that. And not saying to someone, look, the reason your shoulder pops out is because you're anxious about it, but actually saying, I understand you're anxious because your shoulder's not functioning well, but actually trying to address that and working on our breathing and working on our relaxation techniques and working on activating other muscles can really help to settle things down. And a typical pattern for these MDIs is often what we'd call a downward rotation of the shoulder blade. And so what that means is, even though the joint doesn't cup the arm bone hugely well, it's going to cup it even less well if it's tipping down. If you think about a teapot, it's going to pour the shoulder out. And so what that means is all those structures, and particularly in these patients, often their collagen's not great to begin with, so they're just tractioning that. And then what they'll often present with is neck and upper traps tightness and pain. And what people will tend to do is then release that, and then they'll feel worse because that was their compensatory mechanism, the only thing that was kind of holding their shoulder up, as it were. And they'll say, look, I've had physio for 1.5 years. They've done heaps of soft tissue and it feels okay when I first walk out, but then it spasms right back up again. And it's actually that the upper trapezius needs to kick in sooner to help upwardly rotate the scapula in conjunction with some of the other tissues. So that's actually kind of converse to what we learnt as what I would say as a baby physio 10 years ago when I finished uni. It was all about back and down, and it's for no one should it be back and down. It should always be, well, not always.
That's a big thing.
There's a whole podcast in that.
Yeah, it's a big call, isn't it? We'll do a myth busting.
But for these people, and often they'll say, you know, or they'll be, you know, if they are hypermobile, they're often really big fans of yoga because they're great at yoga, but they've been told, you know, open my shoulders, pull them down, and they've got these really downwardly rotated scapulae, which is just not helping their cause. And so it's all about finding that safe position for the shoulder. And they did Andrew Jaggi actually did a study on EMG, and they did a study back home as well. Tanya Pizzari did one where they did live wire EMG. So they're inserting, Andrew's might be superficial, but one was live wire EMG where they actually put needles into the muscle to see what's activating. Nice. And they found, the one that they did that for, they found the upper trapezius is actually underactive in people with multi-directional instability. And you know, you hear so many people saying your traps are overactive, you know, and it's actually potentially not the case, particularly in this population, and I think in a lot of shoulder patients actually, to be honest.
So it can be underactive and feel tight.
Correct.
Oh yeah.
Yeah, so it's on stretch. So it'd be like if I said to you, whack your foot up on this desk and lean over for the next 15 minutes. Your hamstring would start to feel pretty tight.
I can't get on my foot on this desk.
But so it's nothing to do with the strength or lack of strength in the hamstring. It's the fact that it's on stretch all the time. Yeah, it's going to start to tighten to try and protect those neural structures. And if your collagen is loose anyway, your neural structures are already potentially going to be a little bit more vulnerable than if you have nice, strong, tight collagen.
The traps, not the demon we thought.
Not the demon we thought it was. Yeah, so that's one of the things. And actually, I'll give upper traps activation exercises with a TheraBand that they stand on. That's one of the first things that I'll give. If
almost a shrug type of exercise.
A sort of a backing up. So it's what I would liken it to is I normally say to them, imagine you've got a straw on the top of your shoulder and you're sucking your humeral head or your arm bone into the socket. So you're sucking that arm up into the socket. So it's a rotation of the scapula. So it's not a direct upper trap shrug. It's not like an S&C shrug straight up. It's what we're trying to do is tip, so make those shoulder blades smile.
So it's almost like if you kind of touch the back of your shoulder and you'll feel that bone that sort of goes across the top of the scapula, if you follow the angle of it, that's the angle that you're trying to go in. So it's that kind of, that gentle...
Yeah, and normal is about 10 to 15 degrees upward angle.
Yeah.
And so most MDIs are parallel or lower. Yeah. And often it also, to get off slightly off topic, but it'll also often be with a impingement. I know impingement is a term that we're sort of starting to not use so much around shoulders, but if they're dumping their shoulder down and their acromion it is dropping down, it's going to give them less space.
Yes.
So it can actually be something that will help with normal shoulder rehab as well, to look at that, and it's particularly those last sort of above shoulder height, we should see a lovely smooth upward rotation of both scapulae, and if that's not happening, they're going to be either impinging as they come up, or they're going to be sliding out the bottom, depending on whether they're stiff or floppy.
Wow.
So you've mentioned a few times about you kind of got this hypermobility and your shoulder sort of moves around in its socket. So is that how you became exposed to this sort of thing, and why you decide that you love it?
So I think hypermobility overall is poorly managed by health professionals overall, and I think it's I actually did a hypermobility course on the weekend, which was really interesting. And there's a whole lot of other things, you know, with connective tissue, because our connective tissue is through our entire body. Yeah. So you'll often speak to hypermobile people who have also gut issues or heart issues or vision issues, and that all kind of potentially feeds back into these issues they're having with their musculoskeletal system. But no, to be honest, the reason I got into MDI is when I graduated from university, I did a year at the Children's Hospital, and then I moved into private practice, and my boss was a shoulder specialist. And he didn't like the MDIs because they were whingy, and they didn't get better.
So he had passed them off to the new grad.
That's wonderful.
So I,
good teamwork there.
Yeah, and
delegation,
so I started doing them, and I really love problem solving. So I almost did engineering out of university instead of physiotherapy. And I love problem solving. So what I love about MDIs is every single one is different. There's no go-to exercise. It really depends on, I mean, I just said that upper traps is an important one to not overlook, but there's not really a go-to. You've got to look and see how they move and then correct their pattern accordingly. Commonly it is an upward rotation that you need to start off with, and that's, if you're not sure, that's always a good one to start on, because it's not going to make them more unstable. Worst case scenario, it's going to give them a tight upper trap.
Which they probably got anyway.
Exactly. So, you know, it's a really safe one if you're not really sure, but it's such about problem solving, and it's so about finding a safe movement for them. So, for example, in the last 4 MDIs I saw, one is doing the upward trap shrug, Another one is doing an upward trap shrug plus then a gentle sort of press out, so we call it an isometric external rotation, so just gently pressing out with their wrist.
Yep.
One of the other ones isn't even able to do, so they're doing basically holding their arm in a sling hold and then doing that upward trap, upward rotation, because as soon as they let go, their arm slides out the bottom. So it really depends on the level of instability they're getting. And generally above shoulder, if they're really bad, any movement is going to be horrid, and so it's just about desensitizing them to movement, and often starting literally with isometric, so you're getting some muscle activity without having any of that fear of, okay, I've got to move my arm and it's going to pop out. And using manual manual support to reposition the shoulder and get them to do a movement again, and often you can substantially change their movement patterns, and that gets massive confidence and buy-in to your plan of attack.
And how long would you expect it to be? Obviously, you know, two people doing relatively similar exercises, so one with significantly less weight, elbow bent support, kind of coming into that upward rotation, one with their arm by their side doing it. What would their timeframes be that they would expect to see a difference, that they would expect to get better?
Yeah. So, I mean, we know that sort of neuromuscular control is going to change in 2 to 3 weeks. So we know we're on the right track if we're starting to see a change I would want to see a change in symptoms in a couple of weeks, in terms of less dislocations. Obviously, if what we're doing is making them feel like they're getting more dislocations, then we have to readjust.
Change.
I think it depends a lot on, as we spoke about before, how upregulated their nervous system is as well. So if they're really sensitized, it is going to take a lot longer, and it depends on how long they've had the issue for. So my boss, who punted the MDIs to me way back when, but who also taught me a huge amount on shoulders, and I'm endlessly grateful for him, he said the amount of time you've had the injury for, so say it's been 6 months, it's going to take at least 6 weeks to see any change. So if it's 6 months, 6 weeks, 3 months, 3 weeks is where we're expecting to see a change. So if they've had this issue for 12 years, you're going to say to them, look, I'm not expecting to see any change in 3 months, but what we're aiming for is that these exercises won't aggravate your symptoms, you'll become more confident with the exercises, but potentially your day-to-day isn't going to change. And that's one of the really important things with managing these guys, is working out what the time frame is going to be. And I will often slightly overestimate what I think, because then you're never going to disappoint them. And it is so much about the patient. They can't come in and see you once a week and do it. They've got to be doing this all day, every day. You know, it's neuromuscular control. So it's those little shrugs. It's like pelvic floor exercises for the shoulder, right? Is how I often tell people. And so they've got to be really committed to this. And it is probably, I would say for most of them, a good 6 months of pretty solid rehab, and then a lifelong program of doing stuff to manage their shoulder. And that doesn't mean horrible things, but that means, you know, like doing physio exercises twice a week for half an hour. It means finding things that work for you. So for me, it's reformer Pilates, and if I do that regularly, I'm okay, I don't have symptoms. But if I'm a bit lazy and I don't do it for a few weeks, then I might start to feel that things aren't quite so stable.
Different hygiene, really, isn't it?
Yeah, exactly. And so, but it's for everyone, it's a little different in finding what works for them.
You, for the clinicians listening, what are we looking for? When someone comes to you with shoulder issues, what triggers you off to MDI?
Okay, so there's a few things. So number one would be someone that's just not getting better. And they often will have another diagnosis on MRI, as we spoke about. So if their shoulder's sliding around, they'll often have a bursitis, or they'll have a grumpy tendon, because if that's shoulder sliding around in the joint, it's going to knock and irritate things. Also, if they have a concurrent connective tissue disorder, they're so much more likely to have a tendinopathy show up on MRI. So I suppose one of the things that's always going to alert me is that they're not getting better with conventional physiotherapy. The second would be obviously telling you that they feel like their shoulder slides, or a frank dislocation is quite obvious. You know, they're going to say my shoulder pops out when I lift up my handbag. But if they feel like it's not stable, or if they feel like they've got to a certain point in their rehab and then every time they've tried to load it that bit higher, it's dropped off. Often that's saying that real upper traps neck kind of issue. And the other one is age and sort of body type. So often a hypermobile will be quite tall and slim, you know, that sort of body habitus that we're looking at. And often redheads, apparently, are more likely to be hypermobile. We have crappy collagen, apparently. So yeah, if they're fair-skinned, and then obviously there's some different ethnicities which are more likely to be slightly more hypermobile. So someone of Asian or subcontinental descent is more likely to be slightly more flexible than someone who, say, for example, has African American parents. So there is a slight continuum of laxity depending on our genetics as well. Also, if they say one of their parents has had some sort of pathology to do with hypermobility, then that's something as well. But also arthritis. So for me, because, and I don't know, this is something.
Parents
have arthritis. Okay, right. Early arthritis, because sometimes you've worn your joints out because they've been rubbing around like anything. And if you're seeing early arthritis for no reason, so if someone's a thrower, sure, you're going to see some early changes with no real, within any young person. But if you're seeing early arthritic change in someone that hasn't had trauma, or doesn't do a sport that requires repetitive strain, I think that's something that's quite telling that this joint is not stable in the socket. So they're probably the main things for me. Then when you look at them, is that very obvious kind of real drop of those shoulders. Frowning scapulae, exactly. But then the test is to diagnose it. If you're actually wanting to diagnose it, is they've got to have a positive sulcus test. So you pull on their shoulder and you can see the sulcus, but they also have to feel unstable. Right. So I have a positive sulcus. If I pull on my shoulder, I get a divot here, but it doesn't feel nasty to me. It just feels like, someone's pulling on my shoulder. So that would be a negative test.
How does that compare to your other shoulder?
It's slightly more on the one that's more symptomatic, but I have a positive in terms of movement on both sides. I have loose shoulders.
But then you have to match that up with the feeling.
Correct. That's really important. So a multi-directional laxity is what I would have in my shoulders, really, because I don't get a lot of symptoms. So I can feel that my shoulders move more, but they actually don't give me a bother. And to diagnose an instability, they have to have that feeling of,
don't keep, stop.
Don't keep. Exactly. It's that, and they've got to say, that's what I feel, and that's really sore. And then they have to have one other. So then it's either the containment, so you're pulling them up into external rotation, and then looking to see if you give them some support there. Just watch if they're super hypermobile or unstable. If you push too hard, you're going to push it out the back. So that's not going to make it feel any better. So just keep it gentle.
Reece is making faces and thinking, thank goodness I don't see many of these people.
And then passing all of these off to Annabel, I think.
Posterior instability, they're going to say, I don't like washing over my opposite shoulder. So that's a really common one. If someone's got a posterior instability, they're not going to feel comfortable reaching across their body. And if they're not too bad, then all you have to do is give a little push on their elbow, and they're not going to like that because it's going to send out the back there.
So I guess out of what you've just said, a pretty comprehensive list there, but your subjective assessment is so important. Very
important. And things like saying, I don't like picking something up off the ground, which for most other shoulder issues is not too bad. Like people say, I can carry my shopping bags home. It's uncommon for a rotator cuff to hate carrying their shopping bags. Lifting them into the car boot, maybe, but carrying their shopping bags, no. So traction or carrying a heavy backpack. So, Helen will remember that a few weeks ago I decided to jog home with my backpack on, and the next day I called her, I was like, I can't teach the class because I've put my whole shoulder into spasm because of the traction of my backpack just jumping up and down as I ran home. So, but that's probably actually my main thing is if they can't carry a bag by the side, that's a really telling one that there is an inferior instability or a downwardly rotated scapula that they're having issues
nugget
with.
there for anyone with query MDI or a clinician not sure what it is.
And then the other thing I would do is always look to see if their other joints are mobile, increasingly mobile as well. So abatins or just a general look at what's going
on. Mobility.
General mobility, because they may have an undiagnosed hypermobility syndrome, which may need further checking, because a lot of them are accompanied by cardiac conditions, quite significant cardiac conditions. So particularly if you're looking at putting them in the gym or in the Pilates studio, we need to know that they're safe from that perspective. So, some of them will have an aortic dilation, so they should be doing isometrics and things like that, anything that raises their blood pressure.
Great.
Yeah, absolutely. What do we got next?
So, I think there's probably one more question that is key. So at what point with these people would it be conservative management or go see a shoulder surgeon, you are having an operation?
Okay.
And what happens if you've got significant laxity and you've had the operation? How do you function in normal? Because obviously you've got a new normal.
Yeah. So, I think it depends. I wouldn't want to put words in surgeons' mouths, but for me, if they've had an MRI which is normal, they're not a candidate for surgery.
So no structural changes?
No obvious structural change, which which would cause their instability. So yeah, they might have a bursitis, they might have but they are not a candidate for a subacromial decompression if they're lax, because then, particularly for any surgery that they've got to be stuck in a sling, that's going to make their laxity a hell of a lot worse because they can't keep their muscle control happening. So if they're immobilized for any period, that's a disaster. Yeah. So for me, I would send them off, and they wouldn't necessarily even scan if they've had atraumatic instability. So they've just always, they woke up one morning, they sneezed and their shoulder fell out. There's probably unlikely that there's any structural abnormality in there unless they have a congenital condition. So I would definitely rehab for at least 3 months before you scanned them. If they've got a scan and there's no pathology, then unless they are still very lax and they're probably over 40, you'd maybe look, some surgeon would do like a capsular plication or something to tighten the capsule up, but that is a very slippery slope, because then obviously you have the pain, and if it's a muscle issue that's causing it or a muscle spasm issue, that's not going to be fixed by surgery. And having pain after surgery is going to increase that danger response around the shoulder. Yeah. So, there was a patient I had back home who'd had 8 shoulder stabilizations, 8, and was still having recurrent instability. And the reason she'd come in is because she wanted to look at having a baby, and knew that would then make everything looser, but also wanted to be able to pick up said baby. But she'd had 8 stabilizations, which she'd had a bony block for the last one, and it was still unstable.
Was it the same surgeon 8 times?
No. I think about 2 for each.
Right.
Yes, I think it's 4 surgeons, 2 states. So, but she was having recurrent instability. She'd had decent physio, like it was just one of those things. And we got her a bit better, but she's, she doesn't have a normal shoulder anymore. So, but if you've had, say you were a bit loose, so say if I fell over skiing tomorrow, unlikely, so it's the middle of summer, surfing, fell off my surfboard,
and you're not allowed to go anyway.
And I then had a more significant laxity or instability than I previously did, and my scan showed a tear in my labrum, and physio didn't help. Within 4 to 6 weeks, I would then
that's escalated it to a new level.
Correct, and
so
there's a structural lesion. So there has to be, for me anyway, for me to recommend surgery, there'd have to be an obvious structural lesion that fitted with their pathology. So same as spinal surgery, right? You're not going to send someone for spinal surgery if they don't have obvious dermatomal or myotomal injury at the level of their MRI segment. If they've got L5 symptoms and their problem is at L2 on their spinal scan, it doesn't match.
And I think it's that thing of you don't do surgery for pain.
Yeah.
No.
Like, that's not necessarily a good idea.
No.
Always.
Yeah. And I mean, if they have if they have a congenital labral issue, then potentially like a labral reconstruction or a capsular plication could be something that would be helpful. But if it looks generally normal, it's not a pretty sight.
Okay.
Yeah.
Great.
Cool. So, take homes?
Take homes, they take time. I think the other thing is listen to them and actually really take a solid subjective history so that you can make sure that when you set their rehab, you're not giving them something that is a real problem for them. Yeah, exactly. Start small. Start with achievable goals. So if you give them one exercise to take home that they can do really well and they're really confident with, that's so much better than sending them home with 4 or 5.
Yeah.
And really being very positive about it and hearing their just talking to them a lot and giving them a lot of reassurance, I think is a really important thing.
And it's not about pulling your shoulders back and down.
It is not.
No.
About pulling your shoulders back and down. Everything I knew was a lie. Really, Annabel has actually told me that exact thing before. So, second time it'll stick in my head.
The patients have seen you in the last 2 weeks are fine.
Yeah, exactly right. All right, well, thanks, Annabel, for that second part of our chat with you today. I've actually got a hell of a lot out of that.
Yeah, that's fantastic.
So if there are any clinicians or potential patients that maybe have some MDI, have some questions, you're happy for them to get in touch?
Yeah, definitely. I mean, as you can hear from the podcast, I'm happy to talk about MDI all day.
Yeah.
It's one of my
Another one we could have kept going with.
My email is Annabel, ANNABEL, @complete-physio.co.uk. I'm happy to speak, and I'm happy to give clinicians or patients a call if you get in contact me via email to see if there's anything else we can do for you, even if you're in another part of the world or the UK. I'm a member of the Shoulder and Elbow Physio Association, so I can probably give you a recommendation near to your home as well.
Sensational.
Great, fantastic.
All right, well, thanks
you
again,
so
Annabel.
much.
Yeah, that was fantastic. So listen out soon for our part 3 of our chat with Annabel, where we're actually going to talk about some horse riding injuries, which again is something I don't know a lot about, so I'm really looking forward to that one. And again, just a reminder, if you want to go back and have a listen to part 1 of our chat with Annabel, which was all about clinical Pilates, a few gems in there for physios and patients alike.
Yeah, great. Thank you.
All right, excellent. Thanks, Annabel.
No worries.
That concludes episode 5 of the Complete Health Podcast, the second part of our 3-part series with Annabel. As always, for any further information or questions, please feel free to email us at either reece@complete-physio.co.uk or helen@complete-pilates.co.uk. We're also on Instagram at the Complete Health Podcast, which is all one word.
In our next instalment, we chat to Annabel about another area of her expertise, horse riding injuries. And if you enjoyed this episode, please have a look back at last week's episode with Annabel, where she went in depth about clinical Pilates.
So for another week, stay healthy and goodbye.